Welcome to AETCM. Yeah, this is Dr. Nikhil presenting a case. We 63-year-old Pratish Jain. He is from West Bengal. He is a occupation by a worker in Amrita Hospital itself. He is a non-smoker, non-alcoholic, and betel nut chewer. No known comorbidities. Actually came with complaints of loss of appetite, generalized weakness, significant weight loss since 5 to 6 months, and he also had an on and off fever since 1 month. Actually, he presented with the acute onset of lower abdominal pain, dysuria, increased frequency of micturition since 2 days. No history of chest pain, breathlessness, vomiting, or loose stools. No history of any pet exposure, or no history of any prior blood transfusions. No history of any contact with the TB patient, or no family history of malignancy. No family history of TB. Coming to the examination part, on examination, patient is conscious oriented. Pulse rate is 102 per minute, BP 130/80, saturation 96% true air, respiratory rate of around 22. Coming to the general examination, he had a pallor, no icterus clubbing cyanosis, but when we check the lymph nodes, he had a lymphadenopathy. He had a palpable axillary, supraclavicular, cervical, inguinal lymph nodes. It's almost like a generalized lymphadenopathy. So these lymph nodes, when you come to the texture of the lymph nodes, these are large, symmetric and firm, rubbery and mobile and non-tender lymph nodes.
What do you mean by generalized lymphadenopathy?
The spread of lymph nodes, involvement of lymph nodes, three or more than three non-contagious lymph node involvement, then we will call it as generalized lymphadenopathy.
More than two non-contagious groups. If there is an involvement, then only you can call it generalized lymphadenopathy.
So coming to the systemic examination, respiratory, bilateral air entry is there, normal vesicular breath sounds are there, no other abnormal breathing is seen. Per abdomen, patient had soft, he had a mild tenderness, diffuse tenderness, not able to localize that particular quadrant, and bowel sounds are present and no organomegaly. CNS, high mental functions are normal and no other.
Bowel sounds in this case? Why you are bothered about bowel sounds in this case? We are part of examination, we are doing it, but that is not correct. We should be bothered about bowel sounds in this case.
Can be any obstruction, lymphomatous mass obstruction, dynamic obstruction.
Not dynamic obstruction, intestinal obstruction.
So, central nervous system, higher mental functions are normal, no neck rigidity, no focal neurological deficits. So, coming to the labs, we had sent the initial blood investigations. CBC was sent, total counts of around 9.32, which is of neutrophil predominant 90%, in hemoglobin of 9.4, platelets of around 274. And coming to the urine routine showed some 10 to 12 pus cells. And then pre-op serology was sent and it was normal, and LFT total bilirubin was normal, but albumin is 4.2 and globulin is 2.86. And coming to the general electrolytes part, sodium of around 130 and potassium of around 5.1, and calcium of around found to be 12.31, corrected came to around 13.3, phosphate of around 6.2, magnesium of around 3.1. Inflammatory markers, coming to the inflammatory markers per se,
Calcium is how much?
Calcium 12.1 is the calcium, corrected it came to be around 13. Okay. ESR of around 90 and CRP of around 106. So in view of his abdominal pain, we went for a
high calcium is in which all conditions?
Hypercalcemia.
I'm not asking the textbook. You tell me this case.
Particularly in this case,
paraneoplastic syndrome.
As patient had generalized lymphadenopathy, there are multiple differentials. One can be as a paraneoplastic, that can be due to lymphoma. Okay. In lymphoma, we can see thing, and in sarcoid also we can see hypercalcemia. And then
osteolytic lesions.
Apart from this lymphadenopathy, other paraneoplastic like involving per se bone, myeloma we can see, multiple myeloma we can see, and we can also see in some bone metastatic lesions where there will be lysis of bone and which can cause hypercalcemia.
So any granulomatous lesion, infiltration to the bone and sarcoidosis-like condition, also you can get hypercalcemia.
And in view of his abdominal pain and his dysuretic symptoms and also lymphadenopathy, we had first gone for a CT abdomen. CT abdomen showed multiple lymph nodes involving almost around retroperitoneal and inguinal, extensive abdominal and lower mediastinal lymphadenopathy. And then lymph node involvement are retroperitoneal, omental and mesenteric and iliac, and lower mediastinal it's like just a cardiac included in the chest, in the lower part of the thorax. So as this patient had a generalized lymphadenopathy, and my differentials as per the history, as we consider the age, we can consider it as more in the lines of malignancy, but as India is more prone for TB, we can also consider TB lymphadenitis, as India is more center for TB. So we straight away went for a nodal biopsy. Nodal biopsy was, we had sought a plastic surgery consultation, and we have taken biopsy from the approachable side
Pleural
cervical.
fluid analysis. What is the finding? Pleural fluid analysis.
I was showing AD of 266.
266. Okay. So ADA, what is the importance of ADA in pleural fluid analysis?
ADA actually,
Adenosine deaminase.
adenosine deaminase actually it's a if considering the clinical scenario, we can make it specific to certain disease along with the others. ADA per se it's not non-specific. If it can be positive in TB, it can be positive in lymphoma. By comparing the clinical scenario,
Empyema
also we can. By taking the clinical scenario, we have to attribute to it's a diagnostic support for the our differentials.
So what is your idea about ADA in CSF and ADA in abdomen ascitic fluid?
ADA actually in CSF the cutoff value will be 2, but we will be taking more. It's like significant if it is more than 10 in few cases.
Normally ADA has got no value other than in pleural fluid.
Yeah. As a support to diagnosis, we will. So we went ahead with the cervical biopsy, cervical nodal biopsy from the plastic surgery side they have taken. So today only we had got the report. It came as a lymphoproliferative disease.
Okay.
So we had given hematology consultation. And
how do you manage this case? See, patient has come to you. He has got hypercalcemia, breathing difficulty, all these things. How do you manage this case in emergency room? How do you control the calcium? What happened to calcium in malignancy-induced hypercalcemia?
Hypercalcemia itself, it has own differentials. Actually, we have to go according to the first according to the disease per se. In malignancy, particularly, first we will start with the hydration.
When the patient come to emergency room, it always take an ECG
to see for QT intervals.
So that is very important. If QT intervals are changed, then it is an emergency. Otherwise, you can take your own time and treat. Okay, how do you treat it?
We'll start with the conservative line like IV fluids. Even though furosemide diuretics had no role directly per se, but according to the clinical status, if he is volume overload, we'll give fluids and then diuresis one side. If he is not recovering with the fluids, then we have to go for second line like bisphosphonates, or we have to go for calcitonin. If he is having any underlying renal issues, we can't give bisphosphonates, so we can go for biological like denosumab. Or if he is going into the emergency, then we can go for dialysis per se. If we had taken the biopsy and if we are not confirming the infectivity, we can. There is a role of steroids to control hypercalcemia.
Okay. Which all conditions in hypercalcemia steroid will be helpful?
Particularly in malignant conditions.
Malignancy it will be helpful. Other condition?
Sarcoidosis because steroid response
is there. Again, the absorption of steroid will be blocked by the steroid. Absorption of the calcium will be blocked by steroids. Okay. Main thing is fluid and Lasix. In that, fluid is main thing.
In hypervitinosis D also, to prevent the conversion, we can use steroid. There is a little role.
Okay. So what else? What are the other emergencies you can see in lymphoma case?
Lymphoma, particularly if we have any mediastinal lymphadenopathy, we can see superior mediastinal syndrome. There will be compression of airway or compression of esophagus. We can see we have to, whenever patient comes to have a diagnosis of lymphoma to ER with a breathing difficulty, we have to suspect that and we have to make sure that his airway is clear.
What will be the clinical finding of SVC syndrome?
SVC syndrome patient will have, on examination inspection itself, we can see many dilated engorgeous veins, and there will be swelling of the neck, swelling of the face. But jugular pressures are elevated, but we won't see any pulsations in the jugular.
Non-pulsatile JVP elevation.
Non-pulsatile.
Okay. So that will be the clinical finding. Okay. Other emergencies in lymphoma?
Lymphoma, actually, if you know the background of lymphoma, whether chemotherapy had given, and if patient coming with that, we have to suspect a tumor lysis.
What will be the clinical finding?
Clinical finding, patient will having vomiting, diarrhea, lethargy, weakness.
What are the other findings you see in
Seizures will be there. Sometimes if you take ECG, cardiac arrhythmias can be there.
Okay.
If you take lab wise, we can see metabolic abnormalities like hyper or hypocalcemia, hyperphosphatemia, which can cause hypocalcemia, hyperuricemia due to nucleic acid which comes and degrades, forms uric acid, and then we can see magnesium can also be elevated in that.
Then other than that, what are other? See, one is you told mediastinal obstruction, airway compromise. Second thing you told
Tumor lysis.
tumor license. Other complication which patient can come to ER. See, when the patient is coming with a
Neutropenic
lymphoma,
sepsis.
we have to treat the emergency. Afterwards, it is a duty of oncologist to take care of the patient. Next one will be
Neutropenic sepsis.
neutropenic sepsis. How do you manage that?
Neutropenic sepsis, actually we can go for higher antibiotics. The timing of antibiotics very important in the neutropenic sepsis. Picking neutropenic sepsis, not to wait for a higher degree of temperatures. There is no need to wait for a higher degree of minimum tachycardia, or patient is having vomiting or diarrhea itself can indicate neutropenic sepsis, and early initiation of antibiotic is very important.
Okay. How do you prevent neutropenia induced sepsis in hospital?
Reverse isolation.
Reverse isolation. What antibiotic you give to prevent neutropenic sepsis?
Leoflox, quinolones.
Okay, ceftazidime is an ideal antibiotic because that prevents pseudomonas infection. Okay, if the patient is already having sepsis, then you have to go for piperacin azabactam or something like that. Okay, then these electrolyte imbalance you are telling us, so many electrolyte imbalance like this patient, hypercalcemia. Now it is only minimal hypercalcemia. It is increased, then cardiac arrhythmias, VT, all these things can occur. So we have to be very careful. Renal failure. Many patients can come with renal failure. It can be a part of tumor lysis syndrome, hypercalcemia, all these things. Fractures. Many patients can come with fractures, bone infiltration and fractures. Acute myelopathies, fracture-induced myelopathies. Seizures. Seizure lymphoma, is it common?
Yeah, it's common.
It's very common.
Very common.
So in CT, what finding you get? MRI. What will be the finding in MRI if there is a seizure induced by lymphoma? Multiple ring enhancing lesions.
Cortical.
Multiple ring enhancing lesion. Is isolated lymphoma possible in CNS?
Yes, in HIV particularly.
That is also possible. Okay. So what else you want to tell?
So basically, if and not only this, basically, if a patient is having an oncology background, he can present with multiple emergencies to the ER. One will be like an acute airway compromise because of the mediastinal compression, as we said. So initial management, suppose you say superior vena cava syndrome or like a mediastinal obstruction. One thing will be, or basic management will be like to proper the patient, give him a 30-degree raised position, give him water supplementation, and also there are some, even though not clinically proven, there are some role in giving diuretics and steroids in the early stages also in ED itself for supportive management. And also sometimes we may have to, like our airway management, we have to go opt for like smaller size tubes and everything, and also go for an early intubation in this kind of cases, because as the patient worsens, it will be difficult to manage them over time. And also other complications like it can either be like physiologically, like the patient can present with secondary issues, mainly because of deposition of the metastasis. So if the patient is having mets on the spinal cord, the patient may present with spinal cord compression like features. The sudden onset of any paresthesia, weakness, numbness, everything can be presenting. As the presenting illness, the patient can come. Or if it is like on the brain, it can present with seizures. Then if the deposition on the heart, the patient can present with pericardial tamponade, which may again we have to confirm in the ED and maybe have to go for an emergency pericardiocentesis. Then the patient may have like if the patient affecting the lower abdomen, the patient can present with GA obstruction. Like this patient, he didn't pass through for more than 3-4 days when he came to ER. So in the abdominal part, it can be like an acute GA obstruction can be seen in this kind of patients. And suppose the patient is going into tumor lysis, this tumor lysis can cause deposition in the kidney, causing AKA, and the patient may present with acute kidney injury. Sometimes the block can even cause hydronephrosis and again kidney failure. So again, almost all systems can be affected by the secondary deposition of malignancy. And in the electrolyte part, again, as we already discussed, there can be a lot of changes like hyperkalemia, hypercalcemia, hyperuricemia, everything can be seen. So the mainstay, like initial management in ED, our priority will be to hydrate the patient properly. Especially in hypercalcemia, if it is less than 14 milligram, the basic stay of treatment is only hydration, and if required, elastics can be given. But especially in malignancy, it is not recommended. But hydration is the mainstay of treatment, and if it is again more than that, we can go for other bisphosphonate and other mode of management. And again, in hyperkalemia and all, actually, if the patient is showing ECG showing acute changes of hyperkalemia, we have to immediately start the management in ED itself. Like if we have to give other supplementation like GA bolus and all other medication should be given in ED itself. And depending on the other criteria, like the patient's hemodynamic status and all that, if we have time, like other imbalances we have can take time and correct. So hypercalcemia and hyperkalemia we have to manage in ED itself as an acute priority basis. Again, next the complications will be once we start the treatment. Once the treatment starts, the patient can go into like neutropenic sepsis. Then we have to like aggressively start him on the high grade antibiotic, then send cultures as early as possible. And also the patient going into sepsis shock, we have to like resuscitate as early as possible with fluid rehydration and other hemodynamic support like that. So this patient basically we are coming to more like a conclusion of like a lymphoproliferative disorder. Now our further plan will be to like grade the lymphoma, like whether it is to send it for IHC grading and also like maybe like a biopsy and everything.
Classification for lymphoma and all? What type of classification you have?
The anatomical is there. Anatomical classification is there.
What is the basis of anatomical classification?
Above and below the diaphragm.
Above the diaphragm, below the diaphragm.
Below the diaphragm.
That is main thing. Then other classification, sub-classification. That is Hodgkin's, non-Hodgkin's is different. Classification. Above the diaphragm, below the diaphragm. Sub-classification will be
Extent
B
of
symptom plus B symptom minus. What is B symptom?
B symptoms include fever, weight loss, and then
Night sweats.
night sweats.
So that is B plus B minus. Okay. So what will be the basic difference between NHL and HL?
Basically, HL had a good prognosis basically first, and then HL will have always axial involvement.
Axial, middle, like this.
Axial involvement. Mostly it is a contagious spread, whereas NHL it has
it will be above diaphragm or below diaphragm.
It will be mostly above the diaphragm.
Or above or below. Sometimes you can get
Extent
below also. Sometimes you can get above.
Above
also. Mostly it will be confined to one group.
One group.
Then
The classic fever that Epstein fever will be there in the HL group. NHL it can have any type of thing. B symptoms can also be there.
what is this Epstein type?
Patient will have fever for some duration, and then he will have an interval, and then he will have a recurrence. And then treatment wise also various
what is the distribution?
distribution mostly in peripheral, and it mostly extranodal also we can
Peripheral
see.
means what? Which all areas comes in peripheral?
Peripheral we can take epitrochlear or axillary.
Here.
Valdes ring we can
Valdes rings, axilla,
spleen
liver,
and then liver.
epitrochlear, all these things. They are the first involvement. Whereas in HL, it is only in the
Axial,
axial.
mediastinum.
Late stages, it will be similar. Extranodal involvement is more common in
NHL.
NHL. Complications are more common in
NHL.
NHL. Treatment response is more good in
HL.
So there is a major difference.
Major.
Okay. Anything else? Anything else you want to add?
So any patient coming with like prolonged weight loss history with an intermittent night chills and fever, we have to think about like a probable malignancy in this kind of patients. So in ED itself, better we have to look for any obvious lymph node enlargement, which we usually don't do in all cases. So that
What is the basic difference between management of hypercalcemia and malignancy and non-malignancy induced hypercalcemia? Non-malignancy means tuberculosis, sarcoidosis, all these things also you get hypercalcemia. Malignancy also you get hypercalcemia. What is the basic difference? What is the basic difference?
Response to general treatment.
The treatment response is good in
Malignant.
non-malignancy induced this one. Treatment response is poor in
Malignant.
malignancy. Resistant to treatment is a sign of
Malignant.
malignancy.
there are basically three ways actually this thing can happen. One is actually whenever there is a malignancy, there are three pathways which causes hypercalcemia. One is similar to the malignant cells, can be PTH analog or PTH similar cells which can again act like an hormone itself to increase the calcium level. Second will be the actual malignancy may be secondary to like an osteoclastic lesion, so this again can release calcium into the circulation, again increasing the calcium. Third will be again, especially in lymphomas, the lymphoma can have a similar morphology of vitamin D, again causing vitamin D analog like reaction, again increasing the calcium level. So these three are the main etiologies. In this, especially if you're giving steroids, it can suppress the this vitamin D action. So basically, you can again counteract depositing more this calcium into the circulation. So that is one way of stopping this one. Especially in patients with AK, we may not prefer bisphosphonates as an initial line of management.
Anything else?
Uh,
Okay. Thank you.
Thank